everybody. It's a good evening for you from very sunny Cardiff, where the temperature is currently -1 and there is extreme icy condition outside. We are sat in the comfort of our house with abundant heating. So I think you guys should have a good day by this time. So I'm into the graveyard slot. This is the last session. So my job is to take you through at least a taster session of 10 questions with endocrine, and has been introduced. So I work in Cardiff. So this is part 2. So this questions, as you've got the flavor already, would be slightly descriptive with slightly more lab-based information, and it is just to catch hold of this key information which is there individually in each of these questions. So let's take you through the journey of this 10 questions. So the first question is here. Let me just, So this is a 48-year-old lady who was diagnosed with tachyarrhythmias and was started with amiodarone 3 years ago. Her baseline thyroid function was entirely normal. While being on amiodarone, she developed clinical and biochemical evidence of hyperthyroidism, and amiodarone was subsequently discontinued, and this was around 5 months back. But she continued to lose weight and was diagnosed with atrial fibrillation subsequently, which was currently being managed with bisoprolol and apixaban. So she's quite unfortunate. She had tachyarrhythmias to start with, and now that degenerated in some form of atrial fibrillation later. She does not have any family history of thyroid disease, and on examination, her pulse was around 90 beats per minute, which was expectedly irregular, and the blood pressure was reasonable. Clinically, she looked euthyroid with no visible or palpable goiter. So this is her biochemistry. You can see her eosinase are pretty much normal, but the thyroid function still remains abnormal. So her pre-thyroxine is quite elevated. T3 is elevated, and expectedly the TSH is suppressed. But the thyroid autoantibodies, which we commonly do, are the TSH receptor antibody and the thyroid peroxidase antibody, are both found to be negative. So which one of the following is the next most appropriate investigation to distinguish between amiodarone-induced thyrotoxicosis type 1 or type 2? So you can very well sense she doesn't have an autoimmune disease. All her thyroid dysfunction was secondary to use of amiodarone, but despite discontinuing the drug, she still persisted to be clinically and biochemically thyrotoxic. So would you do an ultrasound scan of thyroid without Doppler, a radioiodine uptake scan? Would you do a serum CRP and interleukin-6 levels, or we check the serum iodine levels or the thyroglobulin levels to differentiate between type 1 and type 2 amiodarone-induced thyrotoxicosis? And this amiodarone-induced thyrotoxicosis is very, very common in part 2. You'll invariably get one of the questions based on it. So I hope you have eyeballed the choices, and the answer here is B, which is radioiodine uptake scan. So explanation would be, normally amiodarone-induced thyrotoxicosis are usually of 2 types. Now, type 1 is quite uncommon. It happens only less than 10% cases. And usually it tends to happen in people with pre-existing thyroid pathology, where there is accelerated thyroid hormone synthesis secondary to iodide load. So this is actually iodide toxicity. So this person did not have any pre-existing thyroid disease. There is no palpable goiter, no eye disease, nothing. So if somebody has got these key information mentioned in the stem, then it is very likely the patient has got AIT type 1, that the patient will have a pre-existing goiter or pre-existing thyroid disease, and patients often tend to have positive thyroid autoantibodies. And if you do a radioiodine uptake scan for these people, there will be normal radioiodine uptake. And patients invariably have signs of clinical thyroid disease with goiter and positive thyroid autoantibodies. So this is much more common in people who have got pre-existing thyroid disease or palpable thyroid gland. Thyroglobulin and IL-6 are usually normal, and this condition is usually treated with anti-thyroid drugs. And this is again a question on its own. Amiodarone-induced type 1 thyrotoxicosis is treated with anti-thyroid drugs like carbimazole and propylthiouracil or methimazole. Type 2 is much more common. So this tends to happen in 90% cases. And this is a direct effect of amiodarone on the follicular cells. So this is a variant of thyroiditis, which leads to excess release of T4 and T3. And most of the patients usually don't tend to have any pre-existing thyroid disease, goiter, or autoantibody. So that is what the question fits here. And because it is a thyroiditis, the inflammatory markers will be quite raised. So thyroglobulin CRP, interleukin-6 are often elevated. But like any other thyroiditis, if you subject these patients to radioiodine uptake scan, they will be practically negligible or negative radioiodine uptake. And that's the discriminatory or differentiating features there. But in contrast to type 1, these patients are treated with anti-inflammatory drugs. So this is corticosteroids. So if your STEM says the patient does not have goiter, does not have pre-existing thyroid disease, does not have autoantibodies positive, then the likely answer is type 2 amiodarone-induced thyrotoxicosis, which is treated with corticosteroids. Now, we all know amiodarone is an iodine-rich compound, which is highly lipid-soluble, and therefore it can get easily concentrated in certain glands, namely the thyroid gland, the adipose tissue, muscle, and other tissues. And this accumulation results in inhibition of enzymes which are relating to clearing T4 and reverse T3, or inhibition of entry of T4 and T3 into peripheral tissues. And that is what causes significant disturbance to the thyroid follicular cells. And as I mentioned previously, when you do a color Doppler, type 1 shows increased vascularity and type 2 actually shows the vascularity type to be reduced. And that's the reason why you got negative uptake there. So please be very careful. You have to read this term before you appear for exam. Type 1 and type 2 amiodarone-induced thyrotoxicosis. The treatment will be of very relevance. So type 1 is antithyroid, type 2 is corticosteroids. And of course, you have to read the stem who has got pre-existing thyroid disease or autoantibodies. And that is again differentiating. Okay, number 2. So this is a 55-year-old lady with long-standing history of type 1 diabetes who attended the diabetes clinic for a review. She is currently on a basal bolus regime and has her recent HbA1c was 68 millimoles per mole, so 8.4%, so slightly suboptimally controlled, but she has got very long history of diabetes. She complained of occasional symptoms of dyspepsia, heartburn, and postprandial epigastric fullness, and usually ends up having post-meal hypoglycemia after she does her bolus insulin with meals. And she also has been known to have painful peripheral neuropathy and postural hypotension. So you can very well see this is a lady with suboptimally controlled type 1 diabetes who is on a multiple daily injection regime and already has got complications like peripheral neuropathy and probably autonomic neuropathy, which is manifested as postural hypotension. And now she has got postprandial symptoms, and invariably if she does a bolus insulin, she ends up having a hypoglycemia. So which one of the following would be the best initial treatment for her, whether you'll give her omeprazole, ondansetron, metoclopramide, cyclizine, or chlorpheniramine? So long-standing diabetes with postprandial symptoms, I know you very well get the diagnosis. So this is actually C. So the explanation is this patient, as I've said, has long history of diabetes with neuropathic complication and probably autonomic dysfunction. So therefore, her current symptoms with postprandial dyspepsia and fullness is most commonly or most likely to be related to gastroparesis. And therefore, she will benefit from prokinetic agents like metoclopramide and domperidone as the first option. And you can add in erythromycin, which is again a well-established treatment for a very weird reason in diabetes-related gastroparesis. Cyclizine is an histamine H1 receptor blocker with additional anticholinergic and antiemetic properties. Cyclizine may be tried as an alternative to metoclopramide and in occasions may be used in combination, although this is not used as first line. You can use it as antiemetic, but that is not what the question to this stem is. Omeprazole is a potent proton pump inhibitor, and therefore not the initial choice for gastroparesis. But again, patient has got symptoms of dyspepsia. In clinical practice, you can give omeprazole, but this is MRCP, so you actually direct it to the cause. Ondansetron and chlorpheniramine have predominantly central antiemetic action, therefore they are not relevant here. So by logic, omeprazole would have been a treatment, but that is not because this is an MRCP stem. So we are looking for a prokinetic drug in an established patient with long-standing history of type 1 diabetes with gastroparesis, and that is the answer. Okay. So number 3, I think I did something similar yesterday, but this is slightly different. A 48-year-old female healthcare worker was found collapsed outside her own house. At scene, her capillary blood glucose levels were found to be 1.9 millimoles per liter. So invariably, she was attended by the paramedics, and she was found to have a profound hypoglycemia. Which one of the following investigation would be most appropriate one to establish a diagnosis? Whether you'll go for a serum cortisol and synactin test, or you go outrightly for a CT scan of the pancreas, whether you'll do an extended glucose tolerance test, or a paired insulin plus C-peptide and sulfonylurea levels, or whether you'll go for a fasting plasma glucose and HbA1c level. So she's a healthcare worker found collapsed outside her house with an event of hypoglycemia documented broadly by capillary blood glucose when checked by paramedics. Which one will be the most discriminatory diagnostic test for this lady? So your answer should be D, indeed, yes. But all of these tests are pretty relevant. I will tell you the reason. The trick in this question is mention of a healthcare worker who often have got access to insulin and other oral hypoglycemic agents. So if somebody is working in the healthcare system and want to feign or malign recurrent hypoglycemic episodes for personal gain to seek benefits or get out of work, she can do that. And I have encountered patients, when you charge them outrightly, looking through their eyes, they often acknowledge that this is what they have been doing. And these are the people who needs to be picked up. So MRCP again is very tricky. So you have to read that clue that is already given, a healthcare worker. So they may often self-administer these drugs to seek attention, harm themselves, or for any other personal gains. And abuse of these agents by nurses, doctors, and other healthcare professionals is quite common. So if you look at the bottom table here, if the patient has injected insulin from outside, your endogenous production of C-peptide and proinsulin, which is a precursor of insulin, will be low. So invariably your insulin will be high. But if you have an endogenous hyperinsulinism, either due to hyperplasia of beta cells or due to an insulinoma, then you will see all the hormones are actually, including the prohormones, are high. And C-peptide is released at a 1:1 equimolar ratio with insulin. So everything will be high. And why do we do a sulfonylurea screen? Because it is an insulin secretagogue. So it can also give you a very similar picture, but not quite to the intensity as you would encounter in patients with insulinoma. But because this is a healthcare worker, so we have to do a sulfonylurea screen and see whether the patient has taken any drugs like gliclazide, glipizide, or glibenclamide. But this is a patient with non-diabetic hypoglycemia, so everything is relevant here. Once you have established, yes, the patient has got endogenous hyperinsulinism, invariably we'll do a CT pancreas. So that comes as the next option. Unexplained hypoglycemia in a young person like this can also be due to cortisol deficiency. So serum cortisol and synactin test is also relevant. If you're given with postprandial symptoms where the patient is having symptoms of hypoglycemia after meals, then the reactive hypoglycemia is a common occurrence, and therefore an extended GTT will be very relevant. In patients with diabetes at an onset, because of increased glucotoxicity, patient can also sometimes have hypoglycemia as well. So, or rather, excess release of insulin for the beta cells when you challenge the beta cells all of a sudden. So onset of diabetes can also be manifested as hypoglycemia to start with, but this is not relevant in this term. Normally fasting plasma glucose and HbA1c is used to diagnose diabetes. So this was definitely not relevant. But on a clinical practice, you can also encounter hypoglycemia in early onset diabetes before hyperglycemia sets in. So this is essentially a stem of endogenous hyperinsulinism, and the healthcare worker is definitely not a distraction. That is the clue. So please be mindful about that. Okay. So this is a 41-year-old lady who was referred by her GP and with a 3-month history of weight loss and agitation. She was noted to have mild tachycardia, fine tremor of the outstretched hand, and a small goiter. And her thyroid function was, as you can see, consistent with thyrotoxicosis. So the T4 is raised and TSH is suppressed. Now, invariably, she was started on 𝐴𝐵 𝐴𝐵 40 milligrams once daily, and she was referred to the endocrinology clinic. Now, while she is awaiting to be seen in the endocrine clinic, 3 weeks later, she represented to her GP with a sore throat, and the GP organized a blood test. Systemically, she remained well with no other abnormal findings. Now, these are our investigations. So she's microcytic, not quite anemic, but the MCV is low. Leukocyte count, neutrophils, lymphocytes are reasonably okay. And most of the cell counts are okay. And there are some improvement because it is within just 3 weeks of treatment. There is some improvement in the thyroid function, but the TSH still remains suppressed because it takes at least 6 to 8 weeks for the TSH to recover. So with that in mind, what's the question? Which one of the following is the most appropriate treatment strategy for this patient? So this is a new onset thyrotoxicosis being started on carbimazole. Within 3 weeks, presents to the GP with a sore throat. And you already seen the blood count. Whether you will change carbimazole to propylthiouracil, whether you will stop carbimazole outrightly, whether you will reduce the dose of carbimazole, or you stop carbimazole and start intravenous antibiotics. This will need hospital admission, and whether you will continue carbimazole and reassure the patient. Okay, so the cell count here is essentially normal. So don't get carried away. So answer here is E. You have to continue carbimazole and reassure. Now, in the UK, and I think everywhere, whenever you start methimazole or carbimazole, you have to warn the patient that there is a risk of less than 1% chance of granulocytosis. So once we start patients here, we give a leaflet suggesting that if you develop any new onset fever, sore throat, or rash, which does not subside with conventional measures, then you have to seek attention either of your GP or come to hospital to get a full blood count check to ensure that your patient does not have any idiosyncratic reaction to carbimazole leading to pancytopenia, which may predispose people to neutropenia, and that increases the risk of infections and neutropenic sepsis. So that is what the stem here essentially. So the chances of developing thionamide-induced leukopenia or neutropenia is less than 1%. And patients are routinely warned to present to their GP or hospital if they develop new onset sore throat, fever, or rashes after getting started on carbimazole, so that bone marrow suppression can be ruled out. In this patient, the white blood cell and neutrophils were normal. So you might have a sore throat due to a different reason. It could be a simplest of viral infection. Therefore, carbimazole should be continued. But if there were evidence of neutropenia, the carbimazole should have been discontinued and patient should have been admitted to hospital. If pyrexia was noted, she would have required intravenous antibiotics, and which we often treat with piperacillin, tazobactam, and gentamicin. And once patients are put on treatment, the full blood counts are monitored on a day-to-day basis. They often show spontaneous recovery, but if they are not, then patient may be given with bone marrow stimulant like granulocyte, monocyte, colony-stimulating factor. And this is very routinely done, very routinely done. Okay, so just to ensure, keep a track of the white cell count. If it's neutropenic, invariably, carbimazole should be stopped. You can make a swap to a different tablets once the propyl-thiouracil, but ideally, if you have developed idiosyncrasy to one reaction, we often go for definitive treatment. Either we go for radioiodine treatment or we go for thyroidectomy if that is indicated, so if somebody's got a big goiter and things like that. But in majority of cases, patients do show spontaneous recovery. Whether you re-challenge the patient is, again, we have to have a frank discussion that I can re-challenge you with a small dose of carbimazole later, or make an outright swap to either a propyl-thiouracil, or you can even treat with third-line agents like lithium. But the crux of the matter here is that the patient has not developed neutropenia. It can be safely continued. You can still monitor the full blood count on routine or regular basis. But if there is neutropenia with evidence of pyrexia, the patient has to be admitted to hospital for intravenous antibiotics. Okay, halfway through. Diabetes question. So this is a 49-year-old gentleman with suboptimally controlled type 2 diabetes who was reviewed in the diabetes clinic. He was already on metformin 1 gram twice daily and gliclazide 160 milligram twice daily. So he's on dual oral hypoglycemics. And the HbA1c was noted to be 118 millimoles per mole. So I can tell you this is almost 12 to 13%. His BMI was 24.6 kg per meter square. He was started on once daily intermediate acting NPH insulin because of such high HbA1c. So once the person is started on intermediate acting insulin, which one of the following is the most proper advice to give with regards to oral hypoglycemic agents once insulin was started? So whether metformin and gliclazide both should be discontinued, whether metformin can be continued and dose of gliclazide should be reduced, whether metformin should be discontinued and gliclazide continued in current dose, whether dose and metformin and gliclazide both should be reduced, or whether metformin can be continued and gliclazide should be stopped. So you're playing around with two drugs, somebody who's got a suboptimal or very poorly controlled type 2 diabetes on dual oral hypoglycemic agents started on an intermediate acting insulin. What modification would you make to any of the drugs that has been already given to the person? So answer here is, I think, is B. Metformin can be continued and dose of gliclazide should be reduced. Your main concern here when you're starting a person, this person's age was 49, so she's still young, or person is still young. But your main concern once you start insulin would be whether you are accentuating hypoglycemic episodes in any form. So hypoglycemia would be your biggest concern when insulin is added to a regime that contains sulfonylurea already. Metformin on itself is a hyponeutral drug, so it can be safely continued. In this case, the emphasis should be gradual up titration of insulin dose in accordance with day-to-day blood glucose profile, whether the person make a transition from once daily to twice daily intermediate or a mixture insulin. That is a question of time, how he responds. But once you're given insulin, the dose of sulfonylurea needs to be revised or reduced initially once insulin is added, and may be stopped in elderly. So if you're giving insulin, there is no need for an additional sulfonylurea, which actually goes and stimulates the pancreas. So you are actually enhancing the process of hypoglycemia here. If I'm giving insulin from outside, what's the need of enhancing any remote possible release of insulin from the patient's own pancreas? But this person is young, so the patient can tolerate things. So we can actually just change the dose of gliclazide and reduce it, and where metformin can be continued because it has no reason to give you hypoglycemia. But if the patient is exhibiting symptoms of hypoglycemia or recorded biochemical evidence of hypoglycemia, then sulfonylurea should be discontinued. So then in that circumstances, only metformin and intermediate acting insulin should be continued. So keep an eye on the age of the patient. If it is an elderly person, the gliclazide should have discontinued. If it is not, then you can reduce the dose of gliclazide. But if there's any mention of symptoms resembling or biochemical or clinical evidence of hypoglycemia, then only metformin and the NPH should be continued, and the sulfonylurea should be discontinued. I hope that is clear. Okay, this is a long one, so please read it carefully. This is a 46-year-old lady who presented to the endocrine clinic with 3-year history of progressive weight gain, facial hirsutism, and worsening hypertension. She also has been oligomenorrheic for the last 6 to 8 months. There is history of intermittent global headaches with no obvious galacturia or visual disturbance. So you already got quite a few clues: menstrual irregularities, weight gain, facial hirsutism, and she also got hypertension and global headaches. On examination, her body mass index was high, 32.2, reddish complexion of her cheeks, and her blood pressure was 170/95 millimeter of mercury. There was pinkish abdominal striae, and she had some difficulty in getting up from squatting position. So I think you do have a diagnosis in mind by this time. Let's see what the biochemistry suggests. So you got a plasma glucose, which is random, it is elevated. Thyroid function is reasonable. Estradiol is on the lower side, but she is perimenopausal. Serum prolactin is normal. LH and FSH seems to be okay. Random cortisol is again borderline. ACTH for a morning sample is slightly high. Then there are cortisol specific investigations. So there is a serum midnight cortisol which was done. It was 418. Again, ACTH in the evening was done, which was 33. She had a 24-hour urine-free cortisol. If I say the normal is around, it is actually doubled up. So 574 is quite high. Chest X-ray is normal. Electrocardiogram shows evidence of LVH. And then the suppression test. So we did an overnight dexamethasone suppression test. It was 208. Normally it should suppress below 50 nanomoles per liter. A low-dose dexamethasone suppression test was done, which was done by giving a 0.5 milligrams. So over a 6-hour period for 48 hours. So it should be eight tablets in total. We do a basal sample on 0 day, and then a basal sample after 48 hours. And that should be again less than 50, so it is elevated as well. And an MRI of the pituitary was normal. So what we have established by this time, you can see, is the patient has got hypercortisolemia with features of Cushingoid features. And of course, the ACTH has been found to be high. Now the question. So which one of the following will apply to this lady at this point? She has got Cushing's disease. We need urgent transsphenoidal hypophyselectomy. She has got pituitary-dependent Cushing's disease and will need an inferior petrosal sinus sampling with CRH stimulation. She has PCOS and pseudo-Cushing's and will need an ultrasound of pelvis. She has got Cushing's syndrome due to ectopic ACTH secretion and will need functional radionuclide imaging, something like an octreotide scan. And she has Cushing's syndrome of adrenal origin and will need CT adrenals. So if you want to just see the test again, I'm just going to show you 1 minute. That's your choices. So there is no doubt the patient has got hypercortisolemia with Cushingoid appearance. Now your job and my job is to establish where this is coming from. And it can only come from 3 sources, essentially: a pituitary gland, the adrenal gland, or an ectopic source. So answer here is that she has got pituitary-dependent Cushing's disease and will need an inferior petrosal sinus sampling with a CRH stimulation. There was a clue in the story that she has got global headache. Her ACTH levels are high, so it is an ACTH-dependent Cushingoid features at the moment. So this patient has got pituitary or ACTH-dependent Cushing's disease. And this is evidenced by loss of diurnal rhythm of cortisol secretion. We did show you a midnight cortisol, which is very high. So under normal circumstances, cortisol level at that point should be rock bottom. It should be very low. And patient also has got elevated free cortisol level in the urine and unsuppressed level of cortisol after an overnight dexamethasone suppression and a low-dose dexamethasone suppression test, where the normal level should be less than 50 nanomoles per liter once we give steroid challenge to these people. The ACTH levels are elevated, which concerns a pituitary source as an adrenal Cushing syndrome. Because in adrenal Cushing syndrome, the ACTH will be suppressed due to negative feedback. So if you've got plenty of cortisol secretion from the adrenal by negative feedback, the ACTH should be suppressed. And in an ectopic ACTH secretion, the levels will be much, much higher. And these are often autonomous secretions. For completion, you can also do a high-dose dexamethasone suppression test, which will show again a non-suppressed cortisol level. And we often do salivary cortisol levels as well at 11 p.m., which are often greater than 1 micrograms per deciliter. But the discriminatory test to find out where the ACTH source is to do an inferior petrosal sinus sampling. And we take the level of ACTH. So the ratio between the sample from the inferior petrosal sinus and the peripheral vein and the basal state should be more than 2. And if you give a corticotropin releasing hormone stimulus there, if it's a pituitary dependent disease, the ratio will be more than 3. And this is diagnostic in 90 to 95% cases, suggesting that this is pituitary origin. And because you take sample from both the inferior petrosal sinus, you can also show a lateralization of which part of the pituitary gland is throwing more, invariably, but the patient undergoes a complete hypophyseectomy anyway. If you suspect that there is an unsuppressed level of ACTH, which is very high, then the way to diagnose, of course, you can do a CT scan of the chest, abdomen, and pelvis, but to isolate the lesion, you have to do a radionuclide scintigraphy using an octreotide scan. And patients usually, if they have ACTH origin, and that is ectopic, they often invariably have hypokalemia, and suppression of vagal cortisol after 50 is only up to 50% when you do a high-dose dexamethasone suppression test. And if you go for a CRS stimulation, then they do not show an exaggerated response because it is not a pituitary-dependent disease. So there is plenty way of differentiating the two. Ectopic ACTH has got very high ACTH level. Invariably, the biochemistry will show marked hypokalemia, and you normally need a radionuclide scanning to establish. And if you go for a CRS stimulation, they do not show any exaggerated response. Okay, number 7. So this is a 30-year-old lady who has been monitored by her GP for asymptomatic hypercalcemia for several years. She now presented to the surgical assessment unit with acute upper abdominal pain and dyspepsia, but admitted that she had symptoms of heartburn for several months. So she's known to have hypercalcemia for some time, now has got an acute abdomen, presented to the surgical unit with more dyspeptic symptoms. A CT scan of the abdomen confirmed presence of a small gastric perforation. She had a surgical repair and did very well post-operatively. She was also reviewed by the inpatient endocrine team, who suggested a few tests. So you can see a few tests here, which looks mostly okay. Eugenies are okay. She's slightly renal impaired. The serum calcium level still remains elevated, but her prolactin level has been found to be high. So the endocrine team felt that there might be a possibility of a neuroendocrine tumor here. Which one of the following is expected to be in this scenario? I know Robin has, being a cardiologist, has extensively discussed about neuroendocrine tumors today. So you'll have some inkling here. So whether this is a glucagonoma, whether this is a gastrinoma, this is a vipoma, this is a somatostatinoma, or an insulinoma. So patient with hypercalcemia now has got raised prolactin level and presents with acute abdomen with a gastric perforation. I think you don't need any more clues. The answer is B, gastrinoma. So this is a Zollinger-Ellison syndrome, and the patient has got MEN1. So this patient most likely has MEN1 because he got parathyroid disease, pituitary disease as evidence with prolactinoma, and now has got a gastric perforation due to an ulcer. So this is Zollinger-Ellison syndrome. Asymptomatic hypercalcemia reflects primary hyperparathyroidism, and raised prolactin raises possibility of a pituitary adenoma. So we all know MEN1 is 3 Ps, so parathyroid, pituitary, and pancreas. And 60% of these neuroendocrine tumors in MEN1, so gastrinomas is by far the common. And we see this in a tertiary center quite commonly. 30% are insulinoma, and the rest would be very small. So had I given features of hyperglycemia, that would have been a glucagonoma. If the patient has got very watery diarrhea, that would have been a vipoma. And if it is a patient with say, low blood glucose, then it will be an insulinoma. So besides dealing with the primary problem, of course, the question should not be ending there. She needs to be tested for MEN1 gene, and if this is positive, which is invariably will be, that cascade screening of the family members should be also carried out as well. So you need to test the first and second degree relatives as well. And this is routinely done here. So answer is gastrinoma. Okay, number 8. So this is a 40-year-old lady who was admitted to the high dependency unit after the debulking surgery of a non-functioning pituitary macroadenoma. 18 hours after the surgery, she complained of increased thirst and polyuria and was clinically dehydrated. So she had a large pituitary tumor, had a surgery, and now she has got polyuria and clinically dehydrated. So you can see a specific gravity, which appears to be low, urine sodium of 41, urine osmolality is on the lower side, plasma sodium is high, and the plasma osmolality is high. So which one of the following is the most likely diagnosis? So this is within 18 hours after a pituitary surgery, whether it is cerebral salt wasting syndrome, whether the patient has got water intoxication syndrome, whether this is central diabetes insipidus, or whether the patient has got SIDH, or whether the patient has got nephrogenic diabetes insipidus. I think this is pretty straightforward. So patient is hypernatremic, the volume is concentrated, urine is dilute. There is only one diagnosis here. So this is central diabetes insipidus. But you have to read this terms into very common, this is a very common stem, often given in conjunction with hypernatremia or hyponatremia, and every time that the answer is not a central diabetes insipidus. But this one is pretty straightforward. The patient has a pituitary surgery, so invariably develops significant osmotic symptoms post-surgery. So this is likely central diabetes insipidus within the first 18 hours. So central diabetes insipidus, which is also called now as so it has been rebranded now, called central arginine vasopressin deficiency. It results from the failure of release of antidiuretic hormone from the posterior pituitary. And it is often a triphasic manifestation to start with, after the aftermath of pituitary surgery. And it invariably results in polyuria and increased thirst due to dehydration. And the inappropriate loss of water leads to hypernatremia and increase in the plasma osmolality, but the urine remains dilute. So you will see the serum is actually hyperconcentrated, but every aspect of the urine is dilute. So the urine specific gravity is low and urine osmolality is low. But as you are losing water, your plasma osmolality will be high, and therefore invariably the plasma sodium will be high. So the inappropriate loss of water leads to hypernatremia and increased plasma osmolality, but the urine remains dilute. And this may be associated also with subarachnoid hemorrhage, traumatic brain injury, or after pituitary surgery. And biochemically, as I've said, keep an eye on the urine osmolality, which is usually dilute. Urine sodium does not much have influence here. That will be more relevant in SIDH cases. But if it is very high, that will be reflective of cerebral salt wasting. Plasma osmolality will be high, patient will be hypernatremic, and the urine specific gravity in a dilute urine will be low. So your initial treatment will be giving the volume to the patient. So you have to match the output. So if the patient is peeing out 7 liters, you have to give the patient 7 liters as input as well. And if symptom persists, then desmopressin replacement can be given either parenterally, orally, or intranasally. And this should be continued if the urine output continues to more than 250 mils per hour. In some patients, it often resolves. And in some patients, that is the lingering effect that may persist for a very long period. In cerebral salt wasting, it does not develop immediately after pituitary surgery, but it typically develops 5 to 10 days post-operatively. And this invariably either after pituitary surgery or a subarachnoid hemorrhage. And patients have got hypovolemia with massive urinary loss. So the urine sodium in these circumstances will be very high. And you don't fluid restrict the patient here. You will kill the patient if you fluid restrict. So you have to give the patient normal saline. In contrast, SIDH, patient will be euvolemic, but they present with hyponatremia rather than hypernatremia. And the plasma osmolality and the urine sodium in these circumstances will be more than 20 millimoles per liter. And fluid restriction is the treatment of choice. So you can differentiate individual condition, but these patients are usually hyponatremic. And there is nothing to suggest in the stem that the patient is drinking excess of water because of some mental health, which is due to psychogenic polydipsia. And in those circumstances, everything will be low. Your urine, your plasma osmolality will be low, patient will have hyponatremia, and patient will also pass large volume of urine. But the stem will read as that patient has got mental health problem, they are on antidepressants, and this is the story. So when you see the plasma osmolality, urine sodium, specific gravity, everything will be low. So that is called water intoxication. Okay, number 9, so second last. So this is a 38-year-old gentleman of Asian origin who presented to the General Medical Clinic with 6-month history of progressive weight loss and easy fatigue. He has no other past medical history and does not smoke or drink. On examination, his body mass index was 22, and he also had obvious pigmentation of palmar creases and buccal mucosa. His pulse rate was 78 beats per minute, and the blood pressure was 105/60. So you can see the clues are here. The patient is of Asian origin, weight loss, easy fatigability, low BMI, secondary pigmentation of palmar creases and buccal mucosa, and of course the patient is hypotensive. Very typical MRCP step. Now, what is biochemically abnormal here? Again, some evidence of microcytosis. Serum sodium is low, potassium is borderline, urea creatinine is okay, the ESR is quite raised, plasma glucose is okay, and a 9 AM cortisol is 128 nanomoles per liter. So I'm sure you have a diagnosis in mind now. So which one of the following would be the best investigation to establish the diagnosis? Establish the diagnosis. Whether you go for a CT scan of the abdomen or radio level white cell scan, chest X-ray of the PA view, MRI scan of the pituitary, or you do a CT scan of the thorax. The person is of Asian origin with a very raised ESR and a 9 AM cortisol, which is low. So the patient invariably has got adrenal failure, which we can see. So you'll go for a CT scan of the abdomen. So gentleman present with all features of primary adrenal failure, and because he's of Asian origin, tuberculous adrenalitis is the most likely possibility. But Addison's disease still remains a possibility. But had it been a Caucasian chap, then Addison's or autoimmune adrenalitis is the most common cause. But because if it is Asian origin, then the ESR is also given raised. The tuberculosis is the most likely cause here. So the patient has hyponatremia, mild hyperkalemia, low 9 AM cortisol, and a low, but a short synaptin test is usually required to confirm the diagnosis. But that was not in the step. That would have made it very obvious. So a CT scan of the abdomen is done to show secondary changes in the adrenal gland, either shrinkage in size or calcification. A chest X-ray may be entirely normal in these circumstances. Hence, this would not be the answer in this scenario. So Asian origin man, adrenal failure, all features of primary adrenal failure. You just have to do a CT scan of the abdomen. Okay, last question. So this is interesting. So this is a 40-year-old gentleman who was admitted with a 3-month history of recurrent abdominal pain and watery diarrhea. And he was noted to have an extensive rash as shown in this figure. Which is the best description of this rash? Whether it is erythema chronicum migrans, whether it is necrolytic migratory erythema, whether it is acquired ichthyosis vulgaris, whether it is toxic epidermal necrolysis, or whether it is a bullous pemphigoid. So this is an endocrine station. So please remember that. The patient has presented with recurrent abdominal pain and watery diarrhea, and there is only one disease which characteristically manifests like these type of skin features. I think we have partially dealt with this today. So the answer is B, necrolytic migratory erythema. And the patient's symptoms are typical skin presentation, which are representative of a diagnosis of glucagonoma, which is a neuroendocrine tumor. And the other features that you associate with glucagonoma would be, of course, diabetes mellitus, hypoaminoacidemia, but the patient got plenty of itis symptoms like chiliosis, stomatitis, glossitis, vaginitis, and urethritis. They have normocytic normochromic anemia, venous thrombosis, or neuropsychiatric features. Majority of the glucagonomas are usually malignant, and 90% of these patients will have lymph node or liver metastasis by the time they are diagnosed. And necrolytic migratory erythema is a characteristic rash, which is noted in more than 70% of cases, which usually manifest initially in well-demarcated areas in the groin before migrating to the limbs, buttocks, or peritoneum or perineum. So this is diagnostic of glucagonoma, and none of them otherwise are relevant. So, okay, I think I sign off. Also, I'm done.
I think, Gautam, thank you very much for the nice informative session.